Before we begin, I think it's extremely important to discuss the rotator cuff and its impact. We know through the work of McAlvany in 2015, there's a reported 26% non-healing rate. This has a huge health and economic burden. With soft tissue surgery, there's often prolonged healing, which can inevitably lead to revisions, which can be costly for the patient, the payer, and facility. Additionally, in 2012, there was a reported 115% increase in the number of rotator cuff repairs annually. We also know that the reported total number of rotator cuff repairs annually in the United States is approximately 400,000. And lastly, there's an expected compound annual growth rate of rotator cuff repairs of approximately 4%. So exactly how do we define healing in the rotator cuff setting? Is this simply through patient-reported outcome measures? Is it through healing confirmation with advanced imaging techniques? Or is it simply the ability of a patient to return to activities of daily living or desired activity, pain-free with satisfactory range of motion? Through the work of Robert Kaplan, he advocated that we can only manage what we can measure. So are we measuring the repair of the rotator cuff tendon and coverage of the footprint at time zero? Are we able to measure healing through advanced imaging techniques? And at what cost? MRIs can often be difficult to interpret in the revision setting. CT arthrograms are invasive and irradiate patients. And while ultrasound might be cost effective, it's extremely operator dependent. And is there actually a role for second look arthroscopy in this setting? Some of the various factors that can affect healing include the nature of the tear, patient characteristics, surgical repair techniques, and rehabilitation techniques. Tear classification can be done in numerous ways, either by size, as described by Cofield, the number of tendons, as described by Gerber, retraction, as described by Pate, fatty infiltration, as described by Coutelier, whether or not delamination exists, and the tear location. We also know that a larger tear size and fatty infiltration have been proven to be independent risk factors in non-healing. Certain patient characteristics can also affect the healing rates. Most studies show age to be an independent risk factor for non-healing, and that makes sense. As we age, tendons tend to become more tendinotic, attenuated, and the blood supply to the greater tuberosity decreases. We also know that certain co-medical comorbidities can increase non-healing rates, such as obesity and hyperlipidemia. Interestingly, malnutrition, alcoholism, and diabetes have not been studied specifically with regards to healing rates, though we do know that patients have poor patient-reported outcome measures. NSAIDs have also found to have no harmful effect on healing as recently as 2019 with current doses. Steroid injections have also not been attributed to lower healing rates. However, there are higher revision rates. And lastly, chronic rotator cuff tears have an association of less healing. When we evaluate the surgical repair techniques, it's important to understand the anatomy, the mechanical construct, as well as the biology within that environment. The surgical goal is really to create an enthesis at replicating the bone-tendon interface and hopefully normalizing the tension on the repair. Mechanically, the goal is to obtain a rigid construct at time zero through bone tunnels and anchors. And lastly, improving the biology in that environment to help facilitate healing can be done through bone marrow ventilation, cellular injection, dermal allografts, and xenografts. The goals of surgery and rotator cuff repair are thus high initial fixation strength at time zero, restoration of the footprint, minimizing gap formation, and maintaining mechanical stability through the rehabilitation process. There are currently, in general, two schools of thought on rehabilitation of rotator cuff repairs. The first was described by Alan Deutsch in 2007, advocating for prolonged immobilization or a decelerated program, where a patient essentially is in a sling for 6 weeks with motion initiated after week 4. At 3 months, patients were reported to have stiffer shoulders than their cohort. However, at 6 months, there was improved healing compared to their cohort. There are also contrasting studies that show no differences in healing with a mobilization sooner program. We would be remiss if we did not discuss the histology in this talk when discussing soft tissue surgery. A healed rotator cuff really requires a successful mechanical construct at the time of surgery. And despite a strong mechanical construct and healed tendons, we know that that healing actually differs from the native bone tendon interface. Kanazawa showed this histologically, and on the slide on the right, one can see the differences in cellular distribution, collagen orientation, and chondroid findings. He believes that some of these morphological differences may account for a certain percentage of the rotator cuffs that fail. I'd like to now present 5 surgical pearls. The first surgical pearl is appropriate positioning and portal placement. And as trite as this may sound, it is extremely important. Regardless of the position chosen by the surgeon, access to the entire shoulder joint is crucial. Perhaps one of the best pieces of advice I received was from one of my mentors, who stated, make as many portals as necessary to get the repair complete. Second, identify the tear morphology. Really, the essence of this pearl is doing the surgery in your head before you take action. So classifying the tear and understanding the tear configuration can help with suture anchor placement and suture passage. In this specific example, one can see a crescent-shaped tear and a laminar split. Here, there's several examples of a U-shaped tear that can help one place their anchor and where to pass their sutures. Surgical pearl number 3 is to really address the bone, specifically the acromion and greater tuberosity. It's well known that the acromion can have a detrimental effect and is associated with mechanical impingement, and hence resecting the portion of the acromion without destabilizing the coracoacromial arch may be indicated. This also helps facilitate suture passage anteriorly. In addition, debriding the greater tuberosity gently, not to compromise the subchondral bone, is essential. Surgical pearl number 4 is to mobilize and reduce the tear by resecting adhesions in the subacromial space, as well as on the articular surface of the rotator cuff tendon, with great care not to resect more than 1.5 centimeters medial to the glenoid rim to avoid suprascapular nerve injury. Once this is complete, reducing the tear to identify the exact tear shape and where to place your suture anchors and sutures can be very helpful. In this specific example, there's evidence of an L-shaped tear with the laminar split. And lastly, surgical pearl number 5 is to obtain strong mechanical fixation at time 0. This is done with anchors and appropriate suture placement, along with good knot tying technique. Placing the suture anchor at the dead man's angle through spinal needle localization has been found to be the strongest biomechanical construct. If utilizing an all suture anchor, this need not apply. Appropriate knot tying techniques is crucial, avoiding air knots and cutting free suture limbs appropriately so that the knots do not unravel. And lastly, gently reducing the rotator cuff tendon after sutures have been passed, confirming the sutures do not pull through the tendon. A key pearl here is to pass the sutures approximately 1 centimeter medial to the rotator cuff tendon edge. And lastly, confirming that the entire unit moves as one. Can help improve healing rates. In summary, The surgical pearls are number 1, appropriate positioning and portal placement. Number 2, identify the tear morphology. Number 3, address the acromion and greater tuberosity. 4, mobilize and reduce the tear. And lastly, number 5, obtain strong mechanical fixation at time 0. I'd like to thank you for your attention. If there's any questions, please do not hesitate to get a hold of me. My email is below, anup.shah@bannerhealth.com. I'd like to thank the IASES again for allowing me to speak on this topic. Thank you very much.